8, and she's currently a general practitioner at Belmore Medical Centre, where its vaccination clinics have administered over 25,000 vaccines due to the practice principal, Dr. Jamal Rifi's tireless efforts. So I'll now pass you all on to the capable hands of Dr. Vani Arjunamani.
Thank you, Karishma. Good evening to you all for attending the COVID management webinar, especially dedicating time after a busy Monday clinic and away from family. So Health Professional Network is an organization whose mission is to disseminate health information to colleagues and community alike. This is the second of the Management of COVID webinar. HPN and its parent organization, Friends of India Australia, have been supporting the community through COVID, most recently through delivering health packs, with pulse oximeters partnering with Lighthouse. So some housekeeping for today. Please enter all your questions in the Q&A. Our speakers will respond there. Please provide feedback in the chat. We have a stellar cast of speakers today. So firstly, I'd like to introduce our first speaker, Dr. Ranganathan Rangappa. Dr. Rangappa is an ICU staff specialist working in the southwestern Sydney of Liverpool, Campbelltown and Fairfield hospitals. As you're aware, they bore the brunt of the second wave of Delta. Dr. Rangappa.
Thank you, Vani. Good evening, everyone. Welcome to the webinar. I'm just going to quickly talk about COVID from ICU perspective, since this is my area of expertise, and it's definitely not an extensive lecture about COVID. I'm just going to briefly run through and give you what we do and what can be done to help. As mentioned by Vani, yes, we bore the brunt of it and we're still dealing with it. It's not been fun, trust me. So what is COVID? It's a coronavirus, which is a single-stranded RNA virus, which is likely a zoonotic one, came from bats, and has continued to mutate into the 4th generation from alpha, beta, and now onto Delta, which is the most virulent. It started somewhere in the last quarter of 2019. It's not exactly clear what date it was started. So there have been stories of cases being identified in late November, early December in Wuhan, in Hubei province. It's a very contagious respiratory virus, hence the rapid spread. From China, the next country which was hit really hard was Italy. They got done really bad, mainly because of the way the economic transportation and the workers were being moved in and out of Italy and China. So it looks like that's how it got out of China. And the whole world was very slow to respond to this rapidly progressing virus. World WHO especially takes the cake in slow response and declaring it as a pandemic, which finally happened on the 11th of March of 2020. Vaccine development started straight away within a short period of time as soon as they identified the virus and the genomic sequence. There have been few coronaviruses in the past, including SARS in late 2010, around 12, and the Middle Eastern respiratory syndrome virus. So there's been ongoing vaccine generation development program. So the current vaccination and rapid progress is not that rapid. It's been going on for at least a decade and a half. Coming to the statistics, we like statistics. About 238 million people are affected worldwide. This is only in population which are tested. There have been quite a few countries where either they didn't test or they weren't able to, or it's too expensive and they just went ahead with either completely ignoring it or not reporting. About 4.86 million people are deceased. About 3.65, that's about half of the world's population who've been vaccinated either double dose or at least a single dose. And most of it comes from developed countries. Developing and poor countries are still struggling, and quite a lot of them haven't been vaccinated. And that's where the next problem is going to come. Coming to Australian perspective, we have to till yesterday about 127,470 people infected. Out of them, about 1,432 cases who are people who died. New South Wales, about 69,000, including today's numbers, and about 73.7% until when I last checked are vaccinated. This is 16 and over. If you include the about 12s, the number increases significantly. When did COVID come to Australia? Somewhere in early March, again from returning travelers. Yes, there was a flight which came in and they were isolated in one of the detention centers. There was quite a lot of hoo-ha about it, and finally it snuck in. It leaked through the airport. Our first lockdown started somewhere in mid to end of March. I clearly remember it because all the children's cricket grand finals were cancelled. That hit us hard. We did really well in controlling the spread and flattening the curve. It's very important. I'll explain to you later why. The localized lockdown in northern part of Sydney and the coast was in December. That was in December 2020. And the first dose, our first batch of vaccination arrived somewhere in end of February. And that's when category 1A population, that including frontline workers, was started. So that was in late February, first week of March. There was a rapid uptake among 1A group. Rest of the population, the uptake was very slow, which was compounded by politicization and our leaders declaring it's not a race, we don't need to race for it, and very confusing messages from advisory vaccination advisory committee as well. There were issues with availability, very poor or sluggish promotion, complacency, which was more promoted or propagated by zero case theory. We were confident we would eliminate it, and the social media didn't help. There was language and cultural barriers, and some of it was complicated by religious beliefs and myths. From ICU perspective, in Australia, this was information from about 2 years ago. There might be a few more, couple of hundred more beds with additional bedding. About 2,200 beds in Australia, about 874 to 900 beds in New South Wales. So this includes all regional ICUs. There might have been few additions with flexibility and new beds which have opened up in recent past. Pandemic planning was started straight away as soon as it was declared pandemic. In fact, we were very quick in responding when big hospitals were built in Wuhan, thousands of beds hospital in 2 weeks' time, which really woke up the world, and we saw how people were dying in streets. That did wake us up, but we didn't have, apart from just making contingency plan, there was no real building of new hospitals or opening up big hospitals. We were just trying to reshuffle and reallocate the staffing. Elective surgeries were cancelled, both in public and private hospitals, not only to save beds, it's also to minimize utilization of PPE and also for beds and staffing. They established a single line of command chain. We did improve and help with orders passing both in two directions. There was quite a lot of training and education, both about what evidence was available and what could be done, how it could affect rest of the population and the frontline staff. Additional equipment and staffing were ordered. Unfortunately, we got the tail end of this pandemic. So because we don't have a lot of manufacturing, we did struggle initially with rationing of equipment. We had to either get it from China, which we're using for their own, or from Europe and America, which was again very restricted. So we had to make do. Reallocation of staffing. Yes, once they closed critical areas, including theaters, we managed to get significant amount of staff in the first outbreak. And the beds, again, there were not a lot of new beds of hospitals built either during first episode or second major outbreak. They were just reallocated beds. Most hospitals, at least in southwestern Sydney, run on about 100 to 125% capacity, at least in intensive care. And that was just reallocation, which helped with patients who were being operated electively. We did manage to get zero acquisition of local cases. That gave us a lot of confidence during first outbreak. Delta strain arrived somewhere in June. It had been going on for a few months overseas, especially in US, London and India, which was hit really hard. And they had hundreds of thousands of people dying there over a few months. And it was very, very virulent and contagious virus of the strain. There was increased mortality and morbidity around the world. Second lockdown in New South Wales, Sydney, started on the 26th of June 21 this year. And the spread was compounded by basically initially the overconfidence and complacency that we'll be able to beat it again. We did it first time. Poor vaccination pickup, again, as I explained earlier, and conspiracy theories which didn't help. Pandemic fatigue, this had already set in, both from local experience and overseas. People were fed up. And media didn't really help by saying, oh, well, this is just a bad flu. And politics, that played a bad role. In ICU, again, planning and contingency, training and education with guidelines, PPE, screening, testing, mask fitting, there's a whole heap of precautions and contingencies set in place to preparing for this onslaught. We knew it was coming. We didn't realize or didn't expect that to be that bad. Staffing deployment did help. Communication and regular meeting updates. So there's one chain of command. There are regular meetings for the appropriate staff to attend, both online and on-site, with restrictions to numbers. Once we had significant case numbers, we started redistributing patients. What it meant was we accepted the patients if they need to be resuscitated, tubed, ventilated, we stabilized them and transferred across to different areas. So we transferred patients from down south, from Wollongong, all the way to Hornsby. How did I lose this one? Only I lost my share screen again. Back.
There we go.
Yeah, thank you. ICU, it's a very limited, very expensive, labor-intensive resource. Patients stay anywhere from 1 day to 60 days and an average of about 15. We had patients who stayed there for 2 to 3 months in ICU. Bed numbers is not a true reflection of availability, because the beds doesn't mean there is a available bed which is staffed. So it's the staffing which restricted the number of available beds. Unfortunately, the non-COVID patients didn't get the message. They kept coming. Yes, we stopped them elective surgeries, but the emergencies kept happening. So the traumas, the infections, and category 1 surgeries like cancer, those things had to be done. ICU care was complicated and made difficult by highly infectious virus. Initially, the anxiety, it definitely helped. We had the experience with the first outbreak, the risk of staph infection, taking it home with the videos from overseas where you're not able to visit home. It turned out to be not true. Most of our staff ended up going home, but took thankfully, only one of our staff got infected in Liverpool ICU. There was no other local outbreak in ICU, even though we dealt with patients day in and day out. There was also worry of infecting non-COVID patients in other parts of the hospital. So we had to segregate patients, we had to segregate wards and parts of the hospital, including during transport. So instead of specialty-based rounds, it became ward-based rounds with one specialist coordinating the teams in rest of the hospital. Access to patient was difficult with the PPE, mask, and the glasses, goggles. It was difficult to recognize what you're saying, what you're thinking. They couldn't see our smiling faces. It was just unpleasant, uncomfortable from all angles, both for the patients and for the staff and for families, and minimizing aerosolizing procedures. Families, this was compound speaking background. Sydney Southwest being one of the most complex population with the highest number of non-English speaking people, lack of understanding, poor education, lack of trust in the system and staff, also limited by no visitation rights available for COVID patients and very limited restricted visitation for non-COVID patients, maybe just one family member, and that too if the relative was on deathbed or in terminal stages. Updates were provided by telephone calls on a daily basis and video conference when available. Again, was limited by bandwidth available. We had quite a lot of complaints by families. They lost opportunity to spend last few hours, last few minutes of their relatives' life during their end of life. They couldn't hold their hand. Even after they died, they couldn't touch them, they couldn't visit them. This was painful for us, painful for families, and painful for patients. Social media information and the Google Doctor didn't help. We were threatened by legal implications and taking us to court, threatening with physical abuse, coming and banging on the doors and breaking glasses because they were not being given ivermectin, and mostly it was ivermectin. We just had to stand firm and explain to them what it was. How we overcame these issues: information for families on admission, daily regular family updates patients could see, family members visitation only if there was end of life. This is mostly for non-COVID patients. For COVID patients, they were not allowed. Clearing and de-isolation of patients when suitable, so usually about 21 days after symptoms started, they were cleared, especially if they didn't have any further respiratory symptoms. That was again up to the committee. Early identification and documentation of Corgels, as in CPR for ventilation of aggressive therapy or just for ward-based management. That did help a bit. And engaging with other teams, including family members and senior staff members involved in reviewing patients and making decisions early to stop delayed admission. What were the criteria for admission? So there's only two clear ones. One is patients who are invasively ventilated, mechanical ventilation, and patients who are requiring organ support, which could not be provided elsewhere in the hospital. So this is for our direct ICU admissions, but from GP and other people, it is mainly refer the patients if they're symptomatic, increased work of breathing, or where they're requiring oxygen, where you don't have a provision of oxygen supplementation, or rapid clinical deterioration. They're looking worse, looking tired. Other relative indications, patients who are requiring non-invasive ventilation, rapidly increasing oxygen ventilatory needs, patients who are non-compliant but still for active management, especially with non-invasive ventilation where they would keep pulling things off. They desaturate once they get confused on encephalopathic. It was very difficult to manage them. So in that case, we had no other choice but to intubate them and sedate them. Non-COVID issues in COVID patients like DKA, other bacterial pneumonia, surgical issues, trauma patients, they kept coming. So we had to deal with those ones as well. So those patients are also on routine basis who are generally admitted to ICU or admitted. In patients who are not on any significant NIV, where the saturations are less than 90% with supplemental oxygen, either with high flow or NIV, or a CPAP of more than 10, or FiO2 of more than 40 or 0.4. Increased work of breathing is the other thing which you look at. If they look unwell on supplemental oxygen, which is a bad sign because COVID is a silent killer. So these people were happy hypoxic, so they didn't really have much symptoms. And significant comorbidities, morbid obesity, elderly patients or patients with COPD or diabetes or ischemic heart disease or renal failure would have low threshold to admit them, provided we had beds. And as I mentioned earlier, confused and agitated patients was another clear indication for admission. We aim for saturations of more than 90% if we are able to achieve. We trial them on supplemental oxygen, either with a non-rebreather mask or a high flow oxygen or NIV. Once they didn't show improvement or there was intolerance, we changed them to intubation. Antibiotic, if evidence of bacterial infection, not all patients got antibiotics. DVT prophylaxis for patients who had no DVT or PE. The ones who had PE got full therapeutic anticoagulation. Remdesivir for early in the course of process, which helped with shortening ICU hospitalization and ventilation days. Steroids, mainly dexamethasone for 5 to 10 days, and immunomodulators like monoclonal antibodies, which were mainly started in the second outbreak. In the first one, it wasn't really approved and was very hard to get hold of. So steroids and MABs weren't used in the first outbreak. So with the Delta, we used all these things. Screen them for TB, hepatitis, HIV, and strongyloids. Screen for other infections. We prone them, which was again difficult, but once we had enough experience and staffing, we were able to successfully do this one without causing much harm to patients. But this was again compounded by morbidly obese patients. Some of them were in the range of 150 to 250 kilos. So it wasn't easy. Once they crossed beyond 200 kilos, we just couldn't prone them because they occupied most of the bed. High flow nasal oxygen, non-invasive ventilation, extracorporeal membrane oxygenation was a mode of gas exchange which is delivered in patients who have good chance of recovery, but have less comorbidities and relatively young. Renal replacement therapy, vasopressors, antibiotics and high-dose steroids were used in patients who already had early evidence of fibrosis to treat ARDS. ICU discharge, patients who require less than 50% oxygen are looking well, reduced work of breathing, quite stable patients and not requiring any organ support. Patients who were only for ward-based care, not for further escalation of therapy, change in the mind where they didn't want any further treatment, who just want to be comfortable, and where our treatment was going to make no difference at all. This is pure futile therapy. Very rarely we had requests for patients to go home and die at home, which was incredibly difficult with coordinating with public health, organizing transport and comfort medication. So it wasn't really very easy. The last one, which is meant to be very simple. In post-discharge phase, post-intensive care syndrome, mostly it's post-traumatic stress disorder compounded by dyspnea, chest pains, fever, and anxiety. They had nightmares and traumas, even though we had them on significant amount of sedation. Most of them had functional decline. A significant number of them mentioned they had a foggy brain. They just couldn't function, couldn't switch on and off very quickly or clearly. And there was no improvement in up to 6 months to a year in patients who ventilated for long times or patients who are on significant multi-organ support system. Other medical issues which arose, diabetes, respiratory issues, myocardial infarctions, DVT or pulmonary embolisms, these things which came in, and also hospital-acquired resistant bacterial infections or colonization. That didn't help. So it's a known syndrome. It's a constellation of symptoms, and there's no clear or simple answer to it. It needs to be addressed in multimodal approach. So in conclusion, COVID is a highly contagious, virulent, and potentially fatal illness. It has a very high burden on the healthcare system and on the patients and the staff member, caused quite a lot of anxiety, and is definitely we're going to see further mental health issues, which Sujay hopefully will talk about. What we provide in intensive care is time and support while the body does the healing. Yes, we do give antibiotics which kill bacteria, but most of the process is done by the body. We provide time. We can't win all the battles. Yes, we win quite a lot of them. We don't see it as a victory. We see it as helping the patients, and each patient we stop them from dying and then see them get out of ICU and come back to visit us walking is a big achievement. And that gives us a lot of pride and happiness. And with COVID, it's constantly evolving information about the disease process and other treatments, modalities. There's no hardcore information which is set in stone at the moment. It is evolving and we adopt, hence constant look and updating of literature. More importantly, people need to trust the system and the process. Yes, there are lots of safety net, especially in the public health system. Yes, it delays the delivery of healthcare, but the process works. My last line as an intensivist and a pragmatic specialist, prevention is definitely better than cure. I don't think we can fix this problem very easily. If we can avoid it, please do so.
Thank you so much, Dr. Rangappa. Thank you. Because we're running behind, we're going to leave the questions to the end. It was very good presentation. We found it quite informative. So I'd like to get Dr. Ramakrishna next to have your presentation up while I, So so let me introduce Dr. Ramakrishna, who I have heard of. I've referred many patients to. This is the first time I'm meeting him myself. So Associate Professor Ramakrishna graduated from Newcastle University and completed a dual fellowship in hematology and stem cell transplantation in 1995. He's currently working in Kogarah in private practice and Wollongong Hospital as a staff specialist. He's the associate professor at University of Wollongong in medicine. His research interest includes thrombosis and prevention and low-grade hematological malignancies. So it's apt that he's going to talk about thrombosis in COVID and AstraZeneca vaccine. Dr. Ramakrishna.
Thank you very much, Mani, and thanks to the HPN for organizing this. Trying to load my slides. I'm not sure if it is loaded. Can anyone see it?
Yes. Please go ahead.
Okay. Right, thank you. Look, my brief is on thrombosis and COVID infection vaccines. So I'll be splitting it into two parts. One is just with the infections, and then talk a little bit about the vaccines and what it means from the thrombosis point of view. So as you're all aware that the infection has created a lot of interest and in the community in terms of what it means to them as individuals and as health professionals. It has been quite a challenging thing for just about everyone involved in patient care. So from the infection and the thrombosis point of view, I'll briefly touch on what else it does to our blood and the hematologic system. The virus itself hits just about every cell in our blood and the bone marrow cells, including the white cells. It's very common to find the leukopenia, or in particular lymphopenia, in these patients. and mildly anemic as well, mainly because of systemic illness. And more importantly, there is a significant impact on our platelets and our clotting mechanism eventually that leads to marked disease manifestation or the thrombotic event that may lead to significant morbidities. So we go back to the why it happens, to mechanism as to learning from the disease itself. And it goes back to our own medical school days where, nearly 100 years ago, whatever was described as the causes of thrombosis is really no different. So the Werker's triad of blood vessels and blood flow and blood abnormality, all these three components of the triad are disrupted in the COVID infection. So in COVID infection-associated coagulopathy, there is a wide scale of endothelial cell inflammatory abnormalities plus dysfunction, and the abnormal blood flow dynamics, and particularly the activated platelets, including high concentrations of the activated clotting factors and von Willebrand factor. And all this leads to significant thrombin generation and fibrin formation, and consequently leads to marked thrombotic, prothrombotic phase or response due to the infection, and hence clinical consequences. Looking particularly at the VTE or venous thrombosis, a thromboembolic phenomenon that we see in these patients, there's been a lot of information gathered over the last few years around the world, and there's quite a lot of information in the literature indicating that the infection itself increases the risk of venous thrombosis and pulmonary emboli. And the problem with the varied, we've got anything from 69% down to 21%, or 20% of PE recorded in the literature. So one of the problems for us is to how to interpret this data, and the cumulative incidence is different in time point where they're measured, anything from 2 weeks up to 6 weeks. So therefore, these the numbers vary significantly. But by and large, we sort of accept that around about 30% of the patients do experience significant venous thromboembolic phenomenon. So how do we know this? The COVID infection itself is causing this, and one of the French ICU studies that was published sort of pretty early in the piece, they sort of recorded quite neatly that compared to the non-COVID ARDS patients to COVID ARDS patients, there was a significant increase in the PE that's documented, and also in the overall thromboembolic phenomenon that is that's been documented, and also a slight increase in the stroke manifestations as well. So by and large, we sort of accept that the infection itself causes significant burden on our hemostasis and thrombosis. It's also bits through the test of time, right back in 2019, whatever the data was published to more recent ones, there's always been kind of similar theme, whether it's around about the 17 to 20% of patients manifesting or showing evidence of VTE. So even in the current data, it's sort of very similar to what has been described in the literature a few years ago. So how do we treat these patients? As it's been alluded to earlier on, the ICU patients have a certain protocol of treating these patients, and how we treat these patients in the ward in patients who are not so acutely unwell is slightly different, or thromboprophylactic therapy as opposed to actual venous thrombosis that's well established, needs to be treated a bit more aggressively. So what does it mean to a GP in the community once these patients are discharged? So GPs have to share the burden to a significant degree after these patients are discharged, and vast majority of these patients will be discharged with no anticoagulation, mainly because after the initial therapy and after they overcome their initial insult to their thrombosis, and hemostasis mechanisms, then they're discharged on little or no anticoagulation therapy. But this is partly based on some of the data that's been established or been published in recent times, indicating that in relatively asymptomatic patients, there's no need for them to be discharged from home on long-term anticoagulation therapy, but perhaps short-term. So there is, unfortunately, a slightly increased risk of thrombosis manifestation in the community after they're discharged. So therefore, the GPs have to be mindful of the fact that some of these patients do need to be watched carefully, and we need to individualize the decision on their anticoagulation after they have been sent home. Not everyone needs to be anticoagulated, but certainly there will be a small number of patients that have a past history of thrombosis or increased risk of thrombosis due to anything from obesity to multiple comorbidities to varicosities and venous insufficiency features. They are the ones who are likely to require post-discharge close monitoring or at least some anticoagulation therapy to be considered. So how do we prevent this VTE? Can we come up with a strategy and in patients, if they're in the ward or in ICU, they all get prophylactic therapy unless they manifest with a confirmed case of VTE, then they go on to the therapeutic dosage of anticoagulation therapy. Can the GPs be asked to look at these patients who are in the community, who are asymptomatic and who are doing reasonably well, apart from the serological evidence of COVID virus? So we always put a little a mark of how do we monitor these patients? It is difficult in the sense that there are so many patients that will be coming and burdening our GPs with various questions. And can we come up with some sort of a guidelines that will help us? But unfortunately, the guidelines are not useful from a GP's perspective, particularly if these patients are asymptomatic in the community. But it should again be individualized. These decisions have to consider the individual patient's burden from the thrombosis point of view. So it may be worthwhile looking at each individual case to see if any of these patients would fulfill some of the criteria, like I mentioned earlier, from comorbidities to obesity to varicosities, and particular previous history of thrombosis, particularly the patients who have been treated for DVTs in recent past are at certainly a higher risk of manifesting thromboembolic disorders. So hence it's worthwhile considering putting them on prophylactic therapy. So from moving on from the actual infection causing significant burden to our thrombosis and hemostasis abnormalities and manifestations, going on to the vaccine itself. As you're all aware, it's been quite controversial from the vaccine point of view, and there's been a lot of anxiety in the community, and that sort of provoked anything from the anti-vaxxers to the politicians and just about everyone getting involved, and whether the community should be vaccinated. And in the end, I think there's a vast amount of literature that supports the stance that the infection causes a hell of a lot more problem to our patients than the vaccine itself. And based on the weight of evidence that we all accept that the vaccination is better of the two evils, and hence we have been promoting quite heavily from all the medical point of view that all patients should be considered for vaccination. Interestingly, this cerebrovenous thrombosis following AstraZeneca or any of these vaccines came from Department of Psychiatry and Neurobiology in the UK. So they sort of looked at the vaccines contributing to the cerebrovenous thrombosis. It's not just AstraZeneca, but other vaccines can also contribute to significant thrombosis burden. But compared to the infection itself, this is one of the landmark findings, that the infection causes a hell of a lot more significant manifestation of thrombosis and morbidity and mortality in these patients, and hence it has been advocated that all our patients should be considered for vaccination rather than avoiding it. So we've learned a lot about what it does to our platelets and how it sort of leads to thrombosis. So within a short period of time, the clever scientists have worked out that the vaccine has a propensity to hang on to or trigger a binding effect onto the platelet PF4, platelet factor 4, and generates a new antigen, and consequently it releases certain autoantibodies. So when that autoantibody is released, it has a very procoagulant effect on our platelets. And once we aggregate and activate our platelets, it also has a marked effect on the rest of the thrombosis cascade, and leads to marked cytokine and as well as our pro-inflammatory molecules that eventually leads to manifestations of thrombosis. And why the AstraZeneca causes a lot more of a problem than the other is not clearly worked out, but we know the mechanism in patients with who have undergone AstraZeneca vaccines, but less so in patients who have received the mRNA vaccines. But it is thought to be related to what the mRNA vaccines do to our endothelial and platelets, as opposed to the AstraZeneca vaccine, which has a very marked effect on our platelets directly into triggering a significant platelet hyperactivity and hence a prothrombotic effect. So the pancellular activation of the anti-PF4 antibodies that we see in patients following a AstraZeneca vaccine has been really neatly worked out, and what it does to our neutrophil neotosis, netosis, and as well as endothelial cell tissue factor expression, etc. So the high thrombosis risk in these patients have been reasonably well worked out. But what was unusual or uncommon about these patients is that it not only hits the commonly what we see in patients with venous thrombosis, such as DVTs and PE, but it has a tendency to hit unusual sites like splanchnic or splenic or portal or mesenteric veins, as well as adrenal veins, as well as cerebral and ophthalmic veins. It also has a tendency to hit the arterial thrombosis as well. So there's a significant effect on all of our thrombotic tendency. Therefore, it doesn't really spare arteries or veins, and it can hit any of these spots. So the difficulty in explaining is that, why these unusual sites, these are unusual sites that we normally see in patients who have a certain type of bone marrow disorders, like myeloproliferative disorders with the JAK2 mutation, or paroxysmal nocturnal hemoglobinuria. These are all the unusual or uncommon hematologic disorders that manifest in portal venous or cerebrovenous thrombosis. So it is possible that some of these patients have an underlying tendency yet to manifest, and the vaccine may have unmasked some of these things, and hence these unfortunate patients do manifest significant thrombotic events. So autopsy in some of these individuals who died of VITT have demonstrated significant catastrophic venous thrombosis involving multiple large and small vessels. So therefore, there's significant body of evidence to indicate that the prothrombotic the burden on these patients post-vaccination is real, but it's an extremely small risk. This is a cartoon version of what we learned from our heparin related thrombocytopenia and thrombosis. It's an extremely similar mechanism that we see in patients with AstraZeneca as well. So interestingly, what we have come up with a therapy to overcome this. Immunoglobulin infusion works quite well to block the Fc gamma receptor, and therefore stops the activation of platelets. and consequently reduces the risk of prothrombotic effect, and then significantly clinically quite efficacious as well. So just take it through a small case study. One of our health workers at the age of 49 developed after AstraZeneca vaccine, about 5 days after the vaccine, she developed the usual symptoms of fever and chills and nausea and epigastric discomfort. Over the next few days, she developed more significant aches and pains, particularly in her abdomen, and that required hospitalization by about day 10. So the initial investigations, including blood count and coagulation studies, confirmed the marked thrombocytopenia. The D-dimer was extremely high. Normal is about 0.5, so it's nearly 20. And fibrinogen was lowish at around about 2. So the CT scan confirmed portal venous and mesenteric venous thrombosis contributing to her symptoms. So she was treated with one of the DOACs, rivaroxaban, with a reasonably good resolution of thrombosis and related symptoms, and she was able to be discharged reasonably quickly. I sort of left out the cardiolipin antibody. In her case, there were low titers of cardiolipin antibody detected. It's a bit controversial, mainly because the cardiolipin antibodies can be a transient manifestation following either a vaccine or an infection. So it may be a transient event, but we don't know whether it's pathophysiologically a major concern for this particular patient. But in general, it's a little bit controversial that whether the patients with cardiolipin antibody syndrome do have a markedly increased risk of thrombosis following these vaccines. But the body of evidence is lacking at this stage. But there's a Belgian study that supported a US study supported that there's a possibility of a cardiolipin antibody positivity. It increases the risk of thrombosis following these vaccines, but the Belgian study did not quite support that. So, but by and large, in Australia, we've been trying to avoid giving any AstraZeneca vaccine patients who are known to have cardiolipin antibodies or the related syndrome. So in the from the GP's perspective, how do you investigate the patients with the vaccination-related thrombosis and thrombocytopenia? It's up to around about the 28 days, and in some instances up to 42 days. We extend that. If the patient does present with symptoms and signs of suggestive of thrombosis, we try not to encourage anticoagulation therapy until they have been worked out, unless it's a significant burden. If so, they should be hospitalized. But the initial investigations of blood count and coagulation studies and D-dimers would give you some kind of an idea whether you're dealing with a WIT abnormality or not. If this abnormality, the platelet count is reasonably normal, D-dimer is less than 5 times the upper limit of normal, then consider other causes of the patient's symptoms. So the high D-dimer and a normal platelet count sometimes is commonly seen in a lot of our laboratories, and I do get a lot of phone calls from the GPs and how to manage them. But by and large, we do tell them to keep a close eye on these patients, mainly because they may be manifesting shortly, or it could be a thrombosis in evolution. So the tempo of the disease can change quite rapidly. Therefore, we ask our GPs to keep a close eye on them. So careful clinical evaluation on a regular basis is recommended for these patients with post-vaccination related symptoms. So if the platelet count is low and D-dimer is high, and we sort of recommend they should be hospitalized for further assessment to look for any thrombosis. And if so, they should be treated appropriately in terms of anticoagulation as well as immunoglobulin infusions. If the thrombosis is not confirmed on the imaging, then they do require prophylactic therapy that requires negotiating with your local hematologist as well as your hospital personnel. The other commonly asked question is that, can aspirin have a role in preventing the thrombosis in these patients after a vaccination or even after an infection? But aspirin, particularly after the vaccination, is initially thought as, look, it does have an antiplatelet effect. It does reduce the the platelet activity and activation. Therefore, it's useful, but it failed in a lot of the studies to show that the activation driven by the platelet factor 4 antibodies has no effect in terms of with the aspirin therapy to reduce the risk of these thrombosis in these patients. So it does not have a major role in prevention. In fact, in some instances, there have been cases of bleeding associated with aspirin after the vaccination, particularly if they become thrombocytopenic as well. So the next question of selection of vaccine, and although the pressure on our GPs has eased in the last few months, initially when AstraZeneca versus the Pfizer was the big war, and all of our patients were demanding Pfizer vaccination, otherwise they would not have any vaccination. During that period, a lot of us took a slightly liberal view, and a lot of the patients with past history of any thrombosis, we supported their request for a Pfizer vaccination, although the body of evidence indicates that AstraZeneca is reasonably safe in these patients. Just to allow the anxiety on these patients, we managed to do so, but thankfully at present, a lot of our patients have been able to access the Moderna or Pfizer vaccines. So evaluation of asymptomatic individuals, as noted in the consensus documents, evidence does not support screening these patients or imaging these patients if they're totally asymptomatic after a vaccination. But there will be some instances where the GPs may need to evaluate on an individual basis where they have a significant the venous thrombosis or marked varicosities or venous chronic venous disorders. They are the patients that are likely to manifest as seen in my practice. A lot of these patients do tend to be asymptomatic, but gradually within a matter of weeks, they do develop clinical features of thrombosis. So they do require the GP's attention to ensure that they don't manifest an underlying thrombotic risk. So just coming to our own local experience, these numbers will vary a little bit, and AstraZeneca 1 in 100,000 was roughly accepted as the risk of thrombosis. And in our cohort, the vast majority of were male patients, and majority of the patients had controlled thrombosis, meaning that they did not have a catastrophic event, but there have been case reports of catastrophic outcomes in these patients. So treatment in these patients after AstraZeneca vaccine, we are still advocating a non-heparin anticoagulation, and also not to give them any platelet transfusion despite marked thrombocytopenia, mainly because it adds fuel to fire, and more platelets are given, and it is likely to activate more platelets, and hence a prothrombotic state of affairs. So early commencement of therapy, including immunoglobulins, have been highly effective. Once again, the early diagnosis is the key to improvement of outcome. Therefore, it boils down to our primary care clinicians to bear the burden. The mortality in Australia is better than around the world, but less than 10% has been documented. But we are getting a lot better at managing these patients, so mortality should be a lot lower than what is documented in the literature. So just to sum up, the patients who received COVID vaccination, and they do develop some features of thrombosis clinically presenting to the GP. As I mentioned, most of us, within a month or so, they manifest, but up to 6 weeks, the vaccine-related effect on the thrombosis and on our immune system can last up to 6 weeks. Therefore, we should be vigilant. So the initial investigations of coagulation plus blood count, and if they're all normal, and if the clinical suspicion of thrombosis is quite low, they don't need to be followed up. But if the clinical suspicion of thrombosis is high, they should be managed appropriately with imaging and anticoagulation therapy as you would treat any other patients. But if the D-dimer is, as I mentioned earlier, high, and then thrombocytopenia is noted, so we request our GPs to collect for anti-PF4 antibodies with 4 citrate tubes and 4 clotting tubes, so that it could be sent to a reference laboratory, currently Concord Hospital, where they've been doing all this testing for us. And immediately you need to do some imaging to assess whether they require hospitalization or immediate anticoagulation therapy. So the take-home messages for our clinicians, care clinicians, are that hematological complications post-COVID infections are common and adds to mortality and morbidity. Early diagnosis and therapy certainly reduces the disease burden. Most of the clinical decisions are driven based on the respiratory status of the patient, but one should be mindful of a lot of the asymptomatic patients who may manifest with other clinical symptoms and signs. Secondly, the thrombotic complications of COVID infection is far more greater than the vaccine itself. Therefore, our patients should be vaccinated regardless of choice of vaccine. A lot of our patients have done quite well, but needs a lot of reassurance and gaining confidence of our patients. The use of D-dimer, I touched on that, but there's been a lot of abuse of this testing, and the mild elevation of D-dimer testing has been shown in the community, and it raises a lot of anxiety for the clinicians as well as the patients. But by and large, unless it's at least 5 times their baseline, it is less likely to be a problem. If they're asymptomatic patients, we tend not to investigate these patients. If they become symptomatic, clearly they require all these investigations plus the imaging for thrombosis. And the COVID-infected patients post-discharge may require anticoagulation therapy, as I mentioned earlier. We need to individualize decisions on some of these patients, and we rely on our GPs to bear the burden. Did not have time to go through all the immunocompromised patients and whether they should be getting boosters. So in our practice, we sort of encouraging all our immunocompromised and immunodeficient patients, particularly hematologic malignancies. They all have a poor immune response, and we require a robust T and B cell functioning before our vaccines can have a significant longer lasting prophylactic effect. So if you're looking after any patients with any hematologic malignancies or leukemias or lymphomas or myeloma, or even common variable immunoglobulin deficiency patients, they should be receiving boosters. Now that it's approved, it makes it much easier and more easily accessible. So on that point, I'd like to thank all of you and happy to take any questions if there are any.
I think, thank you so much, Dr. Ramakrishna. We're running quite behind. So I'm getting, if I can invite all the participants to just keep typing in questions. Dr. Rangappa has answered several, and Dr. Ramakrishna will answer in the Q. And if I can ask you to put it in the Q&A section. So without much further ado, our next speaker is Dr. Odette Erskine. She graduated from University of Sydney and completed basic physician and advanced training in the fields of respiratory and sleep medicine at Westmead Hospital. She's also a clinical lecturer for the Sydney Medical School at the University of Sydney, involved in undergraduate and postgraduate teaching at Westmead Hospital. She works as a staff specialist at Westmead Hospital and has private rooms at Westmead Private and North Shore Private Hospital. And she'll be talking about long COVID.
Thank you very much, HPN, for allowing me to talk about long COVID, which is really just an emerging process now, as we are now into the 2nd year of COVID. But we are seeing some patients coming through our COVID clinic for the management of long COVID. This is the things that I was going to have a look at today. And I might just skip to the disease severity for adults with COVID-19. So we have can put it down into mild illness for those adults that really present without any clinical features of any of the following illnesses. They have no symptoms. They may only have mild upper respiratory tract symptoms or some cough and pneumyalgia or asthenia. Moderate illness are those stable adult patients that present to the hospital with respiratory and or systemic signs or symptoms, but can still maintain their oxygen saturation above 92%. Their characteristics include severe weakness, severe asthenia, fevers and persistent cough, and often they will have clinical or radiological signs of lung involvement. Those patients with severe illness are those patients that have a respiratory rate that is greater than 30 breaths per minute. Their oxygen saturations would be less than 92, and they may need additional, obviously, oxygen for the management of this. Critical illness are those patients that we would be sending straight to intensive care if we are not able to manage those patients on our respiratory ward or our high dependency wards. And those are patients that obviously have severe respiratory failure. They may have ARDS, they may be able to progress despite having respiratory support, either with non-invasive ventilation or high flow nasal oxygen. All those patients obviously require mechanical ventilation, which need to be in ICU. So what's the definition of long COVID or post-acute sequelae of COVID? Unfortunately, there's no universally accepted definition of long COVID. It is really generally used to describe those patients that have a lasting symptoms at more than 4 weeks after their initial acute COVID-19 infection. The most common symptoms include fatigue, dyspnea, chest pain, palpitations, headaches, arthralgias, sleep disturbance, or difficulty concentrating. So obviously a whole myriad of symptoms are seen. In terms of the timeline of reported symptoms of long COVID, there's actually quite a vast change in terms of the incidence. So in the UK, in a study is all published obviously this year, 13.3% of patients still had a symptom of long COVID, or those symptoms that I discussed earlier, at 4 weeks. In a US study, this was actually more dramatic, that patients had up to 30% of patients had at least one of the symptoms of long COVID at 4 weeks. In Australia, and I'll discuss about our Australian experience, the documented incidence was about 7.8% at greater than 12 weeks. And another study showed in Victoria that 33% of patients still had a symptom at 45 weeks. This is a long-term issue. It's not something that is obviously going away quickly, and it does affect potentially up to a third of patients that we see. In China, this is even worse, where 45% of patients could experience a symptom at least one symptom for at least a year. So in our Australian cohort, there was a very good study by Liu et al. Who followed 2,904 cases between January and May of last year. They found that of these patients, there was 1.8% deaths, 2% were hospitalized, but importantly, approximately 8% had not recovered by the time of the last telephone contact, which was approximately 3 months. So we've got a big cohort of patients that we need to follow up in our COVID clinics. In terms of just looking at the timeline again, looking at the incidence of recovery, it is good that, look, 60% of patients will recover by 20 days. By 60 days, 90% recover. But at 120 days, only 96 recovered, but there's still that 4% of patients that have not recovered completely from their COVID infection. The most common residual symptoms included cough, which is almost close to 50% of patients, followed by fatigue. And we all know of patients that we've seen that these are the two main issues or symptoms that patients will be experiencing long-term. So how can we identify those patients that might be at risk of long-term COVID? They are often linked to comorbidities. So the increased number of comorbidities will be increasing their risk of long COVID, increasing age, and the female gender. If you're at all worried, I'd be referring to acute services, obviously, if their patients continue to have severe hypoxemia that did not recover after their acute exacerbation. In some patients, we will send patients home with home oxygen, but we would hope that in time that their need for oxygen does diminish. If the patients have had severe lung disease, either prior or at the time of their acute COVID illness, if patients have cardiac chest pain, and particularly in children, if they have a multi-system inflammatory syndrome. So those three comorbidities that were particularly associated with risk of developing long COVID are shown on this forest plot. Those patients that had cerebral vascular disease, those patients that chronic kidney disease, and patients with COPD. So there are 3 comorbidities that I'll be really looking at for those patients that go to that are attending general practice that have these conditions that we really need to watch out for, that these patients might develop long COVID. In terms of looking at the patients that are experiencing symptoms and what kind of symptoms are mainly seen in acute versus chronic COVID illness, we see that in the green, the mild illnesses and the severe illness. So in the acute symptoms, obviously you can have a whole variety of symptoms in the acute illness, but it is those 2, the fatigue and loss of sense of taste or smell, that are reported by patients that have long COVID, and they're quite significant in terms of those symptoms. Looking at age, and as I discussed earlier, that the increasing age does increase the risk of patients experiencing long COVID symptoms. So for those patients aged between 18 and 39 years, 26% of patients might experience long COVID, and this increases by up to, at 65 years, up to 43% of patients will experience long COVID symptoms. Interestingly, we thought that there may have been a difference between those patients that were hospitalized versus those that were managed as an outpatient. And this wasn't borne out in the data, that both hospitalization patients and outpatients both experience long COVID symptoms compared to obviously the healthy participants. So looking at the overall incidence of each long COVID feature in the 180 days after COVID-19, again, we can see, and I saw that someone was talking about anxiety and depression in the Q&A session in the chat, that these patients, this is a big factor. Anxiety and depression is one of those things that will be, that could potentially be a long-term issue. And I know we have a speaker following me that will talk about this, so that would be great. Abnormal breathing is also something that is often seen acutely, but it does still remain at long COVID. Chest pain, again, sort of quite evenly killed, but fatigue and headaches and cognitive symptoms are still all occurring even at the 180 days post-acute COVID illness. So what are the predictors? I talked a little bit about that in terms of increasing the gender as well, so female versus male, and also comorbidities. So of a study that was published in Nature of this year, they looked at 4,182 patients. Most of them were from the UK. And those patients that reported more than 5 symptoms in the first week of their acute illness actually were significantly more likely to experience symptoms at day 28. This was a little bit different from a previous study, but we still really have to be careful of those patients that experienced a lot of symptoms initially may develop long COVID. As I said, increasing age and female gender, particularly those that were less than 70 years in the female gender. In those adults over 70 years, and abnosia was the most predictive symptom of long COVID. Fever was next, then followed by a hoarse voice. So again, it's really important to ask those patients when they come into the general practice of what kind of symptoms they may have experienced in the acute illness and whether or not that may predict those patients that will develop then long COVID. Unfortunately, we do not know the etiology of long COVID. There are some possibilities. The thought are that there may be an abnormality in the response of the patient's immune system. So in some patients, there has been documentation that those patients that had long COVID and then received a COVID vaccination, their symptoms resolved or improved. It may be that because of the patient's immune system, there is activation of certain immune cells like the T cells or the innate immune cells that may be contributing to long COVID. And there also may be a small, persistent, small viral reservoir hidden from detection by diagnostic tests. These reservoirs are not infectious, but may consistently activate the immune system, prolonging the symptoms of COVID. So what's the advice of follow-up care? For those patients that did have a hospital admission, I would suggest an early review at 1 to 2 weeks. Check their medications that they had in hospital. Hopefully that is on the discharge summary that comes with them. talk about their clinical course. They may or may not remember all of their clinical course, particularly if they've been in intensive care, and obviously conduct a physical examination to see if there are any particular symptoms that were affected during their acute COVID illness. It's particularly important to be aware that up to 9 to 15% of hospitalised patients are readmitted within the first 2 months of discharge, and up to 30% can be readmitted within 6 months post-discharge. So they're the patients that we're really concerned about. However, those patients that were managed in the outpatient setting, in the community, I think it still is important to review these patients at 3 to 4 weeks post the recovery of their acute illness to ensure that they are not developing any long COVID symptoms. I think it's really important for all of these patients to monitor their social, psychological, and financial needs post-COVID. We have a clinic at Westmead Hospital for a long COVID clinic, and I think it would be really important in your local area to refer to a local multidisciplinary post-COVID clinic and refer for a comprehensive rehab plan. We have a lot of young patients in their 40s that have really had difficulty maintaining and returning back to their work because of the severity of their illness during their hospital admission, and rehabilitation would be really important for these patients. So looking at the patient history in post-COVID conditions, the whole list of symptoms, but it's really important to really go through a systematic approach and go from sort of top to bottom and ask if these patients do have any of these symptoms. I think it's important to do a systems-based approach. So look for any cardiovascular based conditions such as myocarditis, heart failure, pericarditis. Particularly look for pulmonary issues, whether they've developed an interstitial lung disease or reactive airway disease post-COVID. Have they developed any chronic kidney disease? And as follows, so looking at rheumatological, endocrine, neurologic, psychiatric, hematologic, urologic, and all the others things that can be associated with COVID-19. How do we manage long COVID? It really is a work in progress at the moment. I think it's very important, as I said earlier, to look at the system review, look at their respiratory symptoms. Do they have cardiac symptoms, renal symptoms, neurological, hematological, psychiatric? There's really not much research out there at the moment in terms of how we can manage these long COVID symptoms. There has been a case report by using remdesivir, which can ease symptoms, but really in some patients, there may be only a transient drop in the viral load rather than a sustained reduction. There has been some publications looking at the combination of antibody therapy plus remdesivir, which have shown sustained viral clearance. I think more research needs to be used in this area. A big study looking at using the Recovery Collaborative Group did use casirivimab plus imdevimab, which did help in patients in long COVID. At the moment, we are working out when is the best time to administer COVID vaccination post their acute COVID illness. At the moment, we are recommending between 3 and 6 months post-infection. But again, the research is really not supporting one time or another. However, and we've talked about the vaccination earlier tonight, is that if we can do prevention better than cure, pre-illness vaccination has really showed that those patients that have been vaccinated prior to their illness can reduce their chance of long COVID by 50%. So I think that's really a good example of why we need to have the COVID vaccination on board. And I've come to the end, and I hopefully have made it in time, so we can have any questions or discussion. And I will hand over to the next presenter.
Yes, thank you, Dr. Erskine. We have some questions already in the Q&A, but I really have to ask this question. So vaccines have shown to prevent long COVID in double vaccinated people. However, is there any, I guess the research is sparse, shouldn't we be vaccinating sooner than 3 to 6 months to prevent long COVID in unvaccinated COVID sufferers?
At our hospital, we're suggesting not to do that because they're still really recovering from their acute illness. So we don't want to mask. I think one of the issues is whether or not we're masking any development of vaccine-induced symptoms, or is it secondary to their long COVID. So I think at the moment, our hematologists and our infectious diseases colleagues are actually recommending a minimum of 3 months, not any earlier than that at the moment. But as you say, the research out there is very sparse at the moment.
All right. Thank
We
you
are
very
fortunate,
much.
though, we do have the vaccinations available, though.
Yes,
So
that's the yeah. So thank you very much for that, Dr. Eskin. And if I could guide you to the Q&A, there are many questions for you as well,
Okay.
which I think some of them Dr. Rangappa has answered on your behalf, but there's more. Team effort here today. So now to thank you for all your patience. They're wonderful talks. And I think this is a very important talk that we should all stay for. Done by Dr. Sringeri. So Dr. Sujay Sringeri is a full-time private practice psychiatrist. He works mainly in Liverpool at the aptly named Delta Clinic. He has previously worked in Liverpool Hospital, and he has been a psychiatrist for more than 20 years. Dr. Sringeri.
Thank you for providing this opportunity. I will quickly go through that because of lack of time. Yeah, the outline for this presentation is mainly I look at pandemic and mental health issues, that both psychosocial and biological, and then I will go through other headlines like isolation, mask issues, and vaccine mandate. As we know, pandemic, it's an overwhelming experience for whole population, both public and healthcare workers. And during this period, community and individuals go through very complex interplay between multiple variables. Fine. If you look at this picture, it really explains. And generally, in individual level, there is a threat, and there are multiple emotions going through, and the risk perception, and worried about prejudice and discrimination. Actually, it happens, and disaster and panic in individual level. Then this picture really, if you go through last 3 months, what has happened, this picture really explains. Then come to the leadership, the trust with and compliance with the leadership, and people who can identify with the leadership, and there is in-group elevation, and there are multiple groups in the community involved in the leadership. And in communication, definitely we know there are conspiracy theorists, there are fake news in social media. At the same time, what the authorities can provide, whether they can be persuasive in their communication. In social context, there are social norms, there are different ethnicities, there is social inequalities, different culture, religion, political polarization. Everything plays a big role. And what happens in recent times, what happened in Southwest Sydney and what happened in Western Sydney, what happened in eastern suburbs, that really resonate this picture. And move on to next. The mental health issues happens during the pandemic is mainly fear. I think fear is more communicable than some infections may be more communicable than Delta. The fear of getting infected themselves, their family, and their friends, the major worry. And again, during this period, the information, during this pandemic, what we observed is the even authorities and specialists, they are learning on the go. That's why the information provided was different at different stages. The, for a common man, there is a lack of clarity in this information. There is a lot of confusion. The information provided, as we know, advices change over the period of time. Not how this virus is communicated, the transmitted. Everything is a confusion, and social media is a lot more active during this pandemic than the previous pandemics. And also, there are trust in the government and the leaders all played a major role. And also, the uncertainties about the future. This whole pandemic is constant uncertainties, multiple lockdowns, duration of lockdowns. The lockdowns are imposed overnight, the various factors. And we don't have effective intervention. And as a result, they are not able to estimate the harm. Of course, isolation, disconnection. As Rangappa mentioned, there are a lot of grief-related issues. The family were not able to meet the dying relative. The family is not able to travel to the unwell relatives. There are a lot of grief issues turned into anger and depression. And of course, direct and vicarious trauma. The direct trauma some people have experienced, the vicarious trauma looking at the media, looking at the TV screens, you can see the people here and overseas. And the new challenges. Of course, the whole pandemic has questioned our parental skills. And working from home, homeschooling, these are new challenges. And definitely have a pre-existing mental illness, all these issues become a lot more complex. And psychological consequences related to stressors, it come depression and depressive disorder, post-traumatic symptoms, mainly who are experienced the COVID infection, and also families witness them, and exacerbation of pre-existing conditions. And as speakers spoke about, as we know, COVID-19 is neuroinvasive, goes through olfactory bulb, and also a host autoimmune response can trigger quite a range of psychiatric conditions, and also viral particles passing through the blood-brain barrier through lymphocyte. I think it's called a Trojan horse. Some of the comparison from different part of the world compared to 2019 reports of anxiety, depression is much higher in 2021. These are all non-infected population I'm talking about. But China, they showed 50% or more of depression and anxiety, insomnia and distress. And post-infection, the study compared between the the complication in post-infection compared to other infection and other six major physical illnesses. The psychiatric complication is a lot more in this COVID infection. And another study looked at it's a non-infected individuals, the anxiety and depressive, the infection rates in the community. They are not infected, but looking at the number of cases going up and the extent, the duration of lockdown also directly causing the symptoms. And women or younger people are affected a lot more than other population. And we just heard about long COVID. Again, the psychiatric symptoms a lot more during long COVID reported of fatigue, anxiety, depression, insomnia, and PTSD and brain fog. And some of the commentaries mentioned about the difficulty in communicating some of these symptoms is probably difficult, especially the brain fog and fatigue. And the recommendation is please look out for these particular symptoms, which patients may not be able to communicate, or they will communicate in the form of physical, like aches and pains and the other conditions. And what happened in Australian data? These are ABS COVID-19 household impact survey. It is just before this long lockdown. This COVID, initially it was high in early part of COVID lockdown and subsequently settled, but we don't have data during this lockdown. Women are definitely a lot more affected than men. The younger Australians, if you look at the 18 to 34-year-old population, affected the most in not only experiencing distress in this survey, and also if you look at the the number of calls made to Lifeline and Kids Helpline is much higher. They're talking about it is about 19% higher calls received by Lifeline compared to 2019 April. And also Kids Helpline, it's about more than 11% of in more calls received by Kids Helpline beyond Blue. And another special population affected during this period is the people with disability. And because of the lack of support they received, and whatever the support they were receiving from different agencies has significantly reduced. These are the spread in between August 20 and June 2021. As you said, August was the peak, and gradually it improved when the restrictions are less, and probably during this lockdown, probably it's gone up again. It's interesting to see the data. And before going to next slide, I think it is very important to screen patients, those who had COVID or otherwise. I think K10 has been used widely in these studies, so we don't miss any psychiatric illnesses. So I will move to the next topic, the isolation. We have some experience from early SARS lockdown from different countries. And one of the studies have shown even less than 10 days of isolation has significant mental health impact. The study has done after 3 years after the initial isolation. People still talk about it, post-traumatic symptoms, what they are gone through during isolation. But now we are isolated for quite a long time. I think isolation also brings changes to daily lives and significant loneliness it causes, job losses, financial difficulties, or the consequences. And we heard about panic buying. There was a study by Sydney Uni about where the toilet papers are gone. They compared between Australian population and US population. They mainly looked at, one is the uncertainty, second one is selfishness. I think Australians are proved to be less selfish than Americans in this study. And as a result of isolation, we have more time. There is a binge watching of television, and which is associated with mood disturbance and causing fatigue and impaired self-regulation. And as a result of this, access to services have been, people with disability have significantly affected. There is another article about support groups like Alcohol Anonymous, NAs, and the group therapy activities have been completely stopped or moved to the teleservices, which are not equivalent. And orders and sleep and nutritional rhythm has affected emotional health. And there's a constant exposure to adverse news has been causing more post-traumatic symptoms and excessive spending, online shopping. Online gambling has increased, but actual gambling in club use, I think you're aware, Dan Murphy can provide alcohol within half an hour on your doorsteps. Domestic violence has increased, especially in intimate partner violence. And there has been exacerbation of pre-existing both physical and mental health conditions due to poor compliance and avoidance in seeking help. There is increased helplessness as a whole, causing significant mental health conditions. Next level, the mask mandate. If you look at a couple of studies have looked at it, most of the studies have shown the mask acceptance rate is quite high. In one of the US studies, at 85%. but I raise masks to that extent. Even in peak pandemic, we have not reached 75% actually. And why people refuse to wear mask? This is a lot of explanations given. One is autonomy and personal freedom has been taken away. Whenever things are imposed, people tend to retaliate. There's a perceived threat to their freedom of choice, and there are a lot of non-compliance, anger, questioning the authority and validity of recommendations have been questioned. Again, there are a lot of articles about, initially WHO said keep the mask for the healthcare workers. Subsequently, masks were declared as not useful because not a droplet infection. Then the whole recommendation has changed. When there is a change of recommendation, there is always questions are asked. And there is a widespread question about wearing mask and the health consequences people have raised. There is one American study, I don't know whether to rate it's a small thing. There are various reasons have been given by the population who are not keen to wear masks, like it's forced and it's ineffective. It provides false sense of security. At the same time, people are not able to read others, and they are worried about what other people think about them and offered why they don't want to wear a mask. There are two studies have looked at anxiety going up. There is one study said social anxiety may go up, and some people reported increase in panic attacks. Uh, but in my clinical practice, these questions are asked, and some of the patients with post-traumatic stress disorder uh, reported increase in panic attacks when they wear mask. And in healthy population, there is no harmful or physiological alteration happens. But but some of the patients who requested are having anxiety disorder. I have issued the letter, but generally people with anxiety are so scared. Generally they wear mask in spite of having these letters. And there is one survey from Singapore asking the healthcare workers about mask. They mainly reported discomfort, experiencing headache and lightheadedness uh, when they wear mask more than 6 hours continuously. The vaccine mandate, I think the vaccine debate is a healthy debate. Uh, when patients ask questions, you uh, don't take it as a uh, the mark of disrespect or questioning the authority. But this vaccine has been there are different varieties of vaccines are available, and interaction with on taking medication and the consequences of not having vaccine. And I think the debate should continue. It should not be suppressed. But some of the common the reasons uh, related to vaccine anxiety is one is which is very rapidly developed. For in the previous experience, we know the anxiety that the vaccines take years to develop and launch. And in this case, it came very quickly. People worry about having inadequate research, very skeptical about efficacy, because we know even after having vaccines, some people can contract infection and they are worried about side effects. We know that there are in media. And if there is a person, there's one common thing I have family who is anti-vaxxer or doesn't believe the vaccine, he could influence a lot of people with anxiety. Usually, people with anxiety, they want to do all the right thing, but they are easily influenceable by a strong personality. Other thing is mistrust in the government, especially some of the population, especially refugee population. Their experience in their country is their government is not trustable, but that ingrained thinking may continue in this population. That's it is. These people are not anti-vaxxers. These people need more information and reassurance. They definitely agreed to have vaccine. The other group is non-believers. They are different. They are different from anxiety, people with anxiety. They're anti-vaxxers. They don't believe in vaccine. They're anti-establishment. They have conspiracy theory. They're political for all these factors uh, influence the non-believers. They are different. It is very hard to convert them or very hard to make them take vaccine. The other thing is these non-believers, their communication is very clear and very persuasive compared to how we communicate as clinicians. We talk about positives, negatives, what are the side effects, but the anti-vaxxers, they are very clear. That's why they are more persuasive. What's happening in Australian context? The vaccine take-up is really good. 73% of the people strongly agreed with taking vaccine, which was much higher within a couple of months from May. From reasons people were hesitant to take vaccine was potential side effects and effectiveness of the vaccine. And it's not only in Australia, even the overseas report says after one dose of vaccine, of those who are not received vaccine when the survey was done, there were about more than 55% of the people were ready to go back and talk to their general practitioner. They trusted their general practitioner to get more information, and they were ready to have vaccine. Yeah, this is the picture. I think the vaccine acceptance rate has improved definitely after the second, after this data period. I think vaccine take up is definitely very good. Or what helps, when it comes to the infection, it's a general population. We have to really differentiate between what is normal anxiety, what is abnormal anxiety. The normal anxiety makes us do things properly. You follow all the instructions, you take all the precautions, do all the right things. The normal anxiety improves the functioning, but in abnormal anxiety, it impairs the functioning. People housebound, not contacting others, they're highly distressed, their sleep appetite has been damaged, their social contact impaired. You need to differentiate what is normal, what is abnormal anxiety. As I said, using some of the structured instruments like K10 is definitely useful. It will give you some of the information about their mental health issues. There are tips to cope pandemic was very helpful when the first pandemic. I have a sheet of the techniques to cope with all my patients with appointment. They found very helpful. The mainly I mentioned about maintaining routines and keeping social contacts, regular physical exercises, and limiting alcohol intake and time. Those are really helpful tips the patients used and found it very helpful. And if patient come to you with anxiety, don't go for medication straight away. I think majority of these anxiety symptoms are related to stress, and definitely it's managed by psychological interventions, anxiety management, emotional regulation strategies, and managing negative cognitions are probably the main focus here. And some of the patients with the pre-existing mental health conditions needed titration of the dose of medications. And I think it's a dialogue, it's a time spent. Patients really miss their GPs, face-to-face contact. I think that, and the reassurance about the whole scenario, give a clear information, are definitely found to be very useful. There are some online, the supports are available. You might have heard of the website This Way Up. That's a really very good website. It provides management of anxiety, stress, insomnia, depression. It's a range of support. The website, Black Dog Institute website has a very good tips to cope with pandemic. Beyond the website, the same thing. The last two, I think all the parents should look it up because it gives you in Queensland website, Professor Matthew Sanders. I think he is behind this program. The 20 episodes of parenting in pandemic is a really useful resource. And also there are other resources available for parents in the website I mentioned. I think this is the last slide I have. I'm ready for the questions.
Thank you so much, Dr. Sringeri. We are actually 12 minutes over time, but I will ask this question because I had a patient today who believes COVID is still not real. Would you classify him as a delusional disorder patient? Dr. Sringeri?
If you, it's a false fixed belief shared by and not shared by his social circle. Probably he is belongs to the group of non-believers. Maybe he's shared with other people. We can't call him a non-believer. He is another part of another section of society.
So we need to learn to accept them and live with them in a symbiotic relationship. Is that what you're suggesting?
Yeah, there continued dialogues and continue to discuss various factors with him. Yeah.
Would you agree it's a very hard thing to do for a rational, logical doctor?
I think at some point of time we need to learn to live with different kind of people.
Sure.
They are part of the society. They think differently. Yeah.
Sure. Sure. I think I agree with you entirely. This is a very good lesson for all GPs who are very logical to learn how to, I guess, learn to have patients who are quite antithesis to the way you think. So it's a very good exercise. So thank you so much to all our speakers. And I must say, we are actually 15 minutes over, but thank you for your patience, for staying behind and answering all the questions in the chat. There is actually, there's one more question. So the question is, I'll ask, is there targeted funding for, I guess, psychological conditions as well as long COVID? I'd like to add. Dr. Sringeri, Dr. Eskin?
I'm not sure about, yeah, I'm not sure about targeted funding. Definitely telepsychiatry service have been extended till the end of the year. We don't know what's going to happen next year. Definitely telepsychiatric, the telehealth consultations have been taken up very widely and positively by both professionals as well as the public. In that way, that's one. And there are a range of the programs from different agencies. I don't know about any extra funding. I'm not sure about it because I'm working in private sector. I don't get any news from any public funding now.
Dr. Eskin, is there any specific extra funding for long COVID?
I think at the moment, the hospital system is trying to work out how we can manage these patients. We're going to have a clinic of 100 long COVID patients just at Westmead. So they're trying to work out how we can fund that. So everyone's scrambling to put in proposals and things like that. So hopefully that can be achieved, but I'm not sure.
Okay. And Dr. Rangappa, have you got more funding for the surge coming up?
If I was able to answer that honestly, I'd be a very rich man and one of the most famous person in the world. Unfortunately, the whole thing has been hidden behind layers of secrecy. No one gives a clear answer. That is to tell us how many beds we have. One of the commonest word or the answer, single word answer is fluid. The situation is fluid.
Okay.
No, the clear answer is no. Yes, initially when the outbreak started, there was quite a lot of funding. Again, some of it was diverted elsewhere. Yes, there was probably not adequately utilized. I think we're going to end up running out of money. We're going to struggle. If the
Okay.
numbers increase as expected, it's going to cause trouble.
So one other thing before I close for the evening is I think it's for all the hospital and private doctors. I understand the close contact definition and casual contact definition is changing. What is it in what is it is in ICU? What is it in the wards?
So in ICU, the moment we step into hospital, we wear N95 mask and goggles. So covering both the both mouth and the nose. So with the N95 mask and avoiding direct spray contact onto the eyes. So that if you are exposed to the any patient visual contact, you get swabbed. If you're negative, you go back to work, even though you're exposed.
Okay.
So this is as a casual contact. But if you're exposed to aerosols, then you're still considered as a close contact. So then you have to isolate for 14 days. So again, it is evolving with the increased number of vaccination. They're going to probably redefine the close contact and casual contact and the duration as well.
Sure. What is it in the wards, Dr. Ramakrishna and Dr. Erskine?
And in the wards that we sort of currently it's been wearing N95 plus the special goggles at this stage. So we're back to square one where we were when the second wave hit. So we're taking all the precautions and may not be as stringent as ICU, but certainly back on all the staff, including nursing staff, junior medical, and all the allied health staff are back on using all the masks and goggles.
And we're doing the same at Westmead, and I'm doing the same at in our rooms, private rooms, N95 and goggles to minimize that contact.
And just for people who have private practices, are you insisting your patients have negative COVID test? And if so, how long are we going to do that? Will you be doing that for?
Well, in our we run an outpatient hematology clinic, and we are dealing with a lot of immunocompromised patients. So unfortunately, there are some patients who are not vaccinated. They're not willing to be vaccinated. So, and those patients, it's difficult to turn them away from transfusions and sort of essential medical services. So we try to isolate them, and they have to have a COVID testing 24 hours prior to them being admitted to the outpatient clinic. All other patients who are vaccinated, if they're clinically, we do the screening, but we only insist on 48 hour to 72 hour, depending on the weekend and availability. One of the practical difficulties is that quite a lot of these patients are quite elderly, and they have transportation issues to getting the carers to take them for testing. So there are some logistic problems. So it's sort of a little bit easy on them, but 72 hours is good enough for us at this stage, mainly because all the staff are pretty much well covered from from taking all the precautions. Hopefully the rapid testing may become available, and if it does, that makes it a little bit easier, so that within a matter of hours we may be able to get the PCR results.
Sure. And Dr. Erskine, do you regularly test your own staff as well in your private clinics?
All of our privates, so I've got 2 practices in different private areas. So in one, no. It also depends on the location. So I have got North Shore rooms versus Westmead rooms. Because of the area of concern at Westmead, all staff were regularly tested and still wear the N95 and goggles. In North Shore rooms, they're all vaccinated and wear goggles and mask, but not COVID tested. But all of our patients that come in for aerosols, because we do lung function, they all need to be COVID negative tested before they come in.
Okay. Thank you so much for that. So there's no hard and fast rule that everyone's following. Everyone is setting up the environment to suit their patients. So that's wonderful. So thank you so much for all the speakers. Wonderful sessions tonight. Yes. And thank you for our participants for staying the full hog, so to speak. So I'd like to individually thank our speakers, Dr. Rangappa, Dr. Ramakrishna, Dr. Erskine, and Dr. Shringari, and on typing up all the audience questions. And thank you to our coordinator, Councillor Karishma Kalyenda, and my back-end support, Dr. Vanishi Anand and Dr. Sindhu Ravana, as well as everyone from HPN and Friends of India, Australia, who made this event possible. Thank you and have a lovely night tonight. Thank you so much.
Thank you, everyone.
Thank you.
Thank you.
Good night.